Hello, everyone. This is Dr. Amigues, friendly rheumatologist, for another episode of the Unabridged MD podcast. It is such my pleasure today to have Dr. Francavilla talk with us about some very exciting topic. And you're going to see we're going to talk about the newer drugs to lose weight, as well as the intersection with how to make sure that you do not lose muscle. And you're gonna see it's gonna be an incredible conversation. But without further ado, Dr. Francavilla, thank you so much for being on the show. Can you tell us who you are and how you got into this landscape?
Yeah, well, thank you so much for having me. My name's Carolyn Francavilla. I am a family physician by training, but I am also an obesity specialist. And I've been doing that since the beginning of my career. I always knew that I wanted to help people treat and prevent medical problems through weight loss because of the various effects that excess weight can have in terms of increased risk of heart disease, joint pain, reflux, asthma, dementia, cancer. There's so many ways, diabetes, kidney disease, liver disease, that weight impacts health. And so that was always very interesting to me. And like most people who first have an interest in that, I really thought it was going to be all about diet and exercise, which is certainly an important component. But as I did more education in the world of treating obesity, I really discovered that medications are what will allow people to actually follow the nutrition and exercise programs that they have been wanting to do. So I really am passionate about what I call comprehensive obesity or weight care, which means looking for underlying causes, trying to figure out why someone struggles with their weight, and if there's anything we can resolve or fix there, using nutrition and figuring out a customized plan for someone that makes sense for their life and their body, exercise, which I think we'll talk more about, behavior change, which can mean lots of different things, from reducing stress to changing our relationship to food to simply logging what we eat. And then, of course, the medications, which I've been passionate about for a decade, but I'm so glad that now the world has caught up and we have a lot more medications and more people discussing them.
Yeah, that's really wonderful. And we had another obesity specialist on the show not so long ago. It's been a while, but not so long ago. And we started talking about the GLP-1 agonist and the semaglutide. One thing, because those shows are actually pretty short, we couldn't go into the, a little bit more into the effects of those drugs on muscle loss. And so I was hoping that you could tell us, we talk a lot about, there's a lot in the not the literature, like really more mainstream media, about the face, how do you call that?
Ozempic face, as people like to call it. Yeah.
To us about that. What does that mean and how do we prevent that?
Yeah, so a few things. One of the challenging things about losing weight, regardless of how you do it, whether it's nutrition, exercise, or a medication, is we can't always control where we lose that weight, where we lose fat tissue from, right? The person who wants a bigger butt, ends up losing the weight there. And the person who's really focused on, their face, maybe that's where they lose weight. And so we don't have a lot of control about where we lose weight. And that's why when I use medications and treat people, we always like to redirect and focus on health, right? So Ozempic face is simply when people do lose more of that adipose or fat tissue in their face. And so sometimes people feel like that intensifies wrinkles or makes them look older or just changes their facial appearance in a way that they don't like. Luckily, cosmetically, there is solutions to that if that is really bothersome to someone, which would be filler. So find, a cosmetic doctor who can help if that really is bothersome. But really, when I help people with weight, it's really about improving the risk of diabetes and heart disease, helping people live longer and live better. And so again, we can't always control where we lose fat. And so, yeah, it may make your face look a little thinner. You may not, you may look different, but really focusing on these medications should be used to improve your health. It's really not about cosmetics, in my opinion.
So that said, there are some, like when they looked at the studies, and I went into, pretty deep into the studies of those GLP-1 receptor agonists, because I really love them. Like, I mean, I really, really do love them. And there's definitely clearly loss of muscle.
There
And
can
so,
be. So
Mhm.
when we look at in general, right, even before we have these medicines, when people would aggressively lose weight, say they got bariatric surgery, or we did the other really aggressive method we used to use more was a very low calorie diet. So usually like shakes and bars that were very calorie restricted. People generally will lose some muscle when they are losing weight because most people, some people start off with what we call sarcopenic obesity, meaning they have low muscle and they have extra fat tissue. But the average person has both when they have extra weight. And so most people will lose some muscle mass. And we generally consider it acceptable that, maybe about 25% of your weight loss is losing muscle and 75% is fat. So we want you to lose more fat than muscle. But if you're starting with an average amount of muscle, or you're starting with more than average, with many people at a higher BMI have more than average muscle, then it's okay to lose some of that. And I think one thing we'll see people use more and more in the coming years is body composition, meaning using either DEXA or bioelectric impedance. I use InBody in my clinic, but there's other companies that make scales that allow us to really see if someone losing muscle or fat, and sometimes even where that's occurring. So losing a little bit of muscle has always been considered acceptable. Again, depending on where you start. If you start with really low muscle, then that may be a bigger deal. But most of the time people will lose some muscle. Well, when we look at the data for the meds, it's not disproportionate. So people do lose more fat than muscle in the studies of the medications. And so losing a little bit of muscle is okay. But, in the studies, people were told to eat 500 calories less per day and increase their movement to 150 minutes a week. So really basic lifestyle counseling. They weren't giving really specific advice on what to eat. And so what we find in our clinic is when we track muscle mass and body composition, and when we give people more tailored advice, that we can usually prevent that muscle mass loss or really minimize it.
Okay, that's super cool. So you're a CrossFit trainer in addition to being a physician and an expert and a speaker. I mean, you're, all around pretty incredible. Tell us a little bit about the CrossFit and this program that you created, GLP Strong. Is that what it is?
GLP Strong, yeah. So CrossFit has been one of my enjoyments of the last decade, a way that I de-stress and stay strong. And they've actually done some programs where they've trained physicians on being coaches. So I'm a level 2 CrossFit coach, and I've gotten to use that a little bit with my patients. But what I saw pretty quickly when I was using these medications more and more is that I was constantly telling my patients that they needed to increase strength training. To build muscle, we need to stimulate it. And we do that through strength training, which can be something as intense as Olympic lifting, crazy weightlifting. But a lot of my patients did not have an interest in that. And they wanted to do sort of the least amount they could. They might be interested in walking or swimming or riding their bike, but they really were not that interested in lifting weights, but they knew it was important. And my team kept telling them, like, we've got to preserve your muscle. And so this GLP Strong program really came out of that. I did it with 2 of my CrossFit coaches that I work out with. We designed this program together. I actually refer my patients to them pretty regularly. So they were really familiar with what my patients needed. And what we did is we wanted to create the minimum amount of strength training someone could do to prevent muscle loss. So it's just 20 minutes or so twice a week of really low intensity strength training that you can do in your own home. If you have a small dumbbell or kettlebell, you could use that. But if you don't, we'll show you how you can make a lightweight weight out of a bag and putting a little bit of a water bottle or a can in it. So it's very easy to do. The goal is to prevent that muscle loss and try to improve your muscle quality and strength while you're losing weight on a medication.
That's really cool. I think that can probably like ease the mind of many patients who are like, I'm going to lose my muscle. This is
yeah. And then of course the things we need to build muscle are we need to stimulate the muscle, meaning we need to pull on it, doing some sort of strength training, whether that's Pilates or yoga or weights. And then we need to feed the muscle. We need to give it amino acids to build. So we emphasize increasing protein for our patients when they are on these medications, Oftentimes, our patients will use a protein bar or protein shake that they like to get in enough, or we'll help them figure out where they can get more protein from real foods. But making sure people are getting at least like 70 grams of protein a day, but often we will utilize more than that for our patients on these medications so that they can preserve their muscle while they're losing weight.
Okay, that's very helpful. Thank you. And so I love stories. I think our auditors love stories. And so I always ask for a story of hope, but I almost want to ask for stories. What is the difference between, I feel like all women have tried a weight loss program, at least one, if not two or three or four, 10, right? And so what's the difference with your approach? I kind of know already, but I'm kind of like, I always like to hear it, right? What's your difference in your approach? And then also, like, do you see a before and an after the GLP-1 receptor agonist?
What do you mean by a before and an after?
Do you see a difference of how patients are doing since era
I mean,
of
the medications, the newer ones, so there's older medications that often do work. I think it's really important to point that out because the newer medications can be hard to find. They're often expensive. They're having shortages. And so, a lot of my patients are still choosing our older medications to start with because if they work, they're easier to get, they're more affordable, and they've been out for decades, so we know a lot more about them, right? But when we look at the GLPs, they work more consistently, right? They work for 90% or so of people. So they're a really effective medication. And quite honestly, they are like a magic wand for many of my patients. They suddenly can eat the way they intended to. So instead of feeling cravings at lunchtime, they can eat the salad that they plan to. They're able to eat half a piece of pizza when they have pizza with their friends. They're able to eat a quarter of a cheeseburger. So even when they're having foods that may not be the healthiest, most balanced meals, they're able to eat so much less of it without even trying. Like it doesn't even make them, they don't even consider finishing the food. And so that has been really powerful.
Where is that coming from? Why is it that they suddenly can?
Yeah. So the main mechanism that we use to explain the meds is that you truly feel a lot.
Caroline, I'm not hearing you. Okay, so 9:07. Okay, probably around 9:07. I'll just tell Amanda to take care of this. Okay, let's continue. So, no, that's fine. Like it's the internet. Where were we? So you were talking about. Oh yeah. So let's do it again. Yeah.
Yeah. So the main way we use to explain how the GLP-1 receptor agonists work is on gut hormones. So people feel more physically full when they eat because either the GLP-1 or in the case of Zepbound, the GIP and GLP-1 working together. So they feel more physically full. But we also see that they likely have effects on the brain as well. So people just aren't thinking about food as much. And people often just describe feeling like they have a normal relationship with food for the first time in their life, where suddenly they will crave the healthier meal. It's easier for them to choose. So we predominantly describe it working on those gut hormones, but those hormones definitely have an effect on the brain as well and how we think about food.
That is really, really cool. Okay, so that's a lot of history of hope, but I wonder if you can tell us a story, like one of the stories that made you want to be a doctor in obesity, and then maybe stories that you use for your patients who are losing a little bit of hope when it comes to weight loss.
So I would say, one of my favorite patients that I see often when I go to the gym, which is part of what I like about seeing him. He did take one of these medications. He tried everything, right? The average patient that comes to me, they've already tried everything. They've tried every nutrition program, every diet, sometimes every other medication. And he started Zepbound. And he lost a lot of weight and he was feeling great. And then the sort of discount program for the medication went away. And so he stopped the medication. We switched him to an older medication, phentermine, which is a cheap generic medication to sort of maintain. And over the time that he was on the medication, he started exercising every day. He, for the first time in his life, is doing pull-ups at like 50 years old. Maybe he's even older than that. Like doing pull-ups, like just whipping them out at the gym now. So it's been really cool to see the way he was able to transform. And we expect most people will need to stay on the medication, but he has able to be so consistent with exercise and with his nutrition and with a little bit of an older generic medication that so far he's maintained that weight. And again, he's doing these fitness things that he could never do before. I have another patient who also we had tried a really complicated medical history, including binge eating disorder and type 2 diabetes. And she went on Mounjaro, which is the same med, but for diabetes, and I think she's lost about 100 pounds now. Her diabetes is controlled, and she's also about 50. And so she started working more on the exercise because I really pushed that. It's very important for our health, no matter what our weight is. And it's really important to maintain weight. People don't lose weight from exercise. It is how they maintain weight. And so it becomes really key, not just for our heart health, our muscle health, but to maintain weight. So I pushed her more and more to exercise. She started doing some online programs. She actually started going to our CrossFit gym and working with those trainers. And everyone kept telling her she needed to get 10,000 steps in a day. So she was walking every day. And then one day she decided to start running instead because she's like, I can get my steps in quicker. So now this lady is running 3 miles every day. And she went from being someone who had severe obesity, type 2 diabetes, honestly was pretty sick to someone who runs 3 miles a day. And so that transformation and seeing what people are able to do with their weight loss to me is so powerful, right? A lot of times in Western medicine, physicians will tell people to just exercise and eat healthy. And I think we kind of have it backwards. Those things are easier to do when you've lost weight, right? It's a lot easier to run when you've lost 100 pounds. It's a lot easier to do a pull-up when you've lost 70 pounds. And so to me, those are some of the power of the stories and the medications of bringing it all together, right? The meds are not going to do all the work for you, but they will let you do what you've always wanted to do.
I love it. Well, thank you so much. I feel like I could ask you so many more questions, but I see the time, and this is supposed to be a short episode in general for Unabridged MD. Where can our auditors find you?
Yeah, so I have a podcast, The Dr. Francavilla Show, if you want to hear more about health and weight. And then our new strength program that's specifically for people who are on a medication and people who have not currently been doing any strength training is called GLP Strong, and that's at www.glpstrong.com.
Love it. Well, thank you so much again for coming on the show, Dr. Francavilla, and thank you for all of the information, and we'll make sure that we have everything in the notes so that people can follow you and follow you on your podcast as well. So have a wonderful day, and see you everyone next week. And if you like this show, and if you don't hesitate to share it and review it. That's how we get a little bit more exposure. Take care.